Welcome to this poster on supporting clinicians in their integration of patient-reported outcome measures in their everyday practice. I'm Dr. Angela Wolf. This is part of a project funded by the Canadian Institute for Health Research Patient-Oriented Strategy. This project is based on the assumption that input from clinicians matters as end users of PROMs and how it can in terms of their knowledge, professional practice, and clinical decision-making. This presentation is part of a larger systematic review, and here you can see our question that was asked. The methods are documented in this publication from Systematic Reviews, published in June of 2021. And our project will create a user guide that will supplement some of the well-known resources by ISQL. Here is our Canadian framework or consolidated framework for implementation research. We're going to focus specifically for this presentation on processes and in particular the implementation science theory called ERIC, Expert Recommendations for Implementing Change by Powell and 2015 and Perry 2019. There are three key areas out of the A to J that I'm going to talk about that clinicians talked about greatly in the published literature. First, we'll start with the evaluative and iterative, or first we'll start with assessing and redesigning workflow. To assess and redesign workflow, not only perceived, reality, and ideal, there was a number of different accounts in reference to time, 82 accounts, workflow, 24, and workload, 16 out of our publications that were included. Clinician workflow can include a number of things. As simple as scripts for assessment or data collection to more important things like what are the roles and responsibilities of the various team members. And also keep in mind everybody's, the clinician work schedules vary greatly among the different disciplines. A lot of times the clinical processes create these time burdens or do not match the usual routines. So this is very important from the end user perspective. As well, we have redesigning care and provider interactions, clinical pathways, and mitigating any double work that results from the implementation of PROMs. The second strategy is looking at the need to conduct needs assessment from the end users, starting with the selection of the PROM. We also then need to consider the various work procedures, as well as things about how do we design patient instructions, the interpersonal abilities of the clinicians to be able to do this, their needs in terms of data display, score interpretation, how the PROMs data informs their decision-making, and so forth. And finally, highly talked about is the need to train and educate stakeholders, not only initial, but also ongoing training and adapting that to the local context. Given the tenure of clinicians often in a workplace may be less than 6 months up to 2 years, this ongoing training is essential. Most of what people talked about was how to use PROMs, which referred to not only knowing about patient-centered care, but specific knowledge about the PROMs topics such as quality of life. Communication skills were a key piece of this, as well as score interpretation, integration of the data for practical utilization, and within that then includes the clinical reasoning to incorporate this subjective data, and most importantly, the shared decision-making and what clinicians do when they address challenging issues that maybe is outside of their clinical expertise, like psychosocial matters. Insights gained from this is that the input from clinicians matters, ideally around workflow, their needs assessment, and continual ongoing training. I want to acknowledge this is part of a larger funded project, Guidelines for Healthcare Providers' Application of Patient-Centered Measurement in Practice. Thank you. And contact me if you'd like further information.